Thank you so much, Farouk, for joining us on a podcast at Dawdle.live. We're extremely grateful to have an hospital leader with us today, and we'll touch upon a lot of topics which kind of will help a lot of leaders around, especially in the healthcare segment, learn from your experience. But before we begin, would you like to take 1 or 2 minutes to give, a context of your experience and your journey so far?
Absolutely. Rishikesh, thank you. Thank you for having me. I mean, it's a great opportunity here. And it's been good to discuss something, about the realities of healthcare. So I'm Mohammed Farouk. I'm the Chief Operating Officer at Rela Hospital. It's a hospital in Chennai. It's a 450-bedded hospital here in Chennai. My roots are from Madurai, which again is in the southern part of India. It's a small city in Tamil Nadu. I did my schooling there and I did my BSc in microbiology, followed by my master's in biotechnology. So right after that, I started working in cancer research. And till date, I kind of have a soft corner for research, really, which is why I am actually still finishing my PhD. So I've applied for my PhD after a long time, started working on it because we were doing some fantastic work right after college. Research in India at that particular point of time wasn't so flashy. The government also was more keen on agriculture and what it can actually use. I wouldn't blame them. But I was more interested in cancer because I'd lost a few relatives to cancer. And what I was thinking more on was the diagnostic approach. So I was there. Then I moved to Chennai to a hospital, again, more on a research role, and then moved on to the administrative side of it, tasted the business blood there. So my family has come down from Gujarat. I don't look like a South Indian, but we've settled down in Madurai for business, and we've got a good textile business happening. My brother takes care of it. So business has been in the blood. So as soon as I had an opportunity and I did it, it just came very naturally to me. And then since then, I've been in the hospital industry for about almost 20 years. Today, I'm here with Dr. Rela at Rela Hospital. We are doing phenomenal work here. And I'm happy that we'd be able to share something.
You have been in the industry for the last 20 years.
Mhm.
What are the biggest operational challenges that you face while you are balancing patient care quality with financial sustainability?
That's a really good question, Rishikesh. I mean, you've gone right for the neck there. I think what I would rather say is, I mean, the biggest challenge, at least for me, what I think is balance. Because as a private hospital, we've got a mission to deliver the best quality of care, the highest standard of patient care. It has to be safe, it has to be timely, it has to be compassionate, and of course, outcome driven. And on the other hand, you have to also ensure that it's financially feasible. It's sustainable and you're not making a loss really. And one way to do that is to ensure that you're able to invest back into the hospital to ensure that you're up to date with technology, with talent, with great infrastructure. So this balancing act that I'd call it, is what I would say is key. Because see, if I want to invest in a machine, of course that'll have a bit of capital cost. It will translate to more of just setting it up there. But if I can use it for better patient outcomes or maybe operational efficiency, or something like that reduces surgery time or the length of stay of a patient, then it actually justifies the cost. So when you look at expenses also, I don't think that the biggest leaks in institutions are the big leaks, the big spends. Rather, I'd say that it's the small recurring expenses that come, they're very tiny. And it's sometimes very difficult to pinpoint these. So we've picked up on that over time, thanks to a lot of AI as well. So we focus on efficiency, of course, without compromise. What we try and do is we bring in processes to identify these pain points and work towards that to improve our efficiency.
Farooq, since you have touched upon this, is that we'd also like to understand a few use cases of technology interventions that you have implemented in your career and have worked out well, solved proper business challenges.
I think, I mean, when you're talking about digitization, I think healthcare is a bit of a late starter, but post COVID, I think we're getting there. Uh, we hospitals were not very digitally equipped, but now I think they're doing a fantastic job. AI has been a life changer actually, and we've got technology everywhere. The idea is that people still think that hospital is a service industry. I think we've moved from that point and we've moved to something more of an experience industry because people come in, people have got their own journeys here. And what we have to try and get done is to ensure that the journey of the patient within the hospital, whilst they're here, whilst they're getting treated, not only gives the best standard of care, but also gives them a good experience whilst they're here. And we use technology for smaller things like queue management to auto recognize people as soon as you walk inside. The cameras recognize who you are, picks it up, to all your files being digitized, to fantastic AI based queue management softwares. I think we've got softwares that can help read scans really and make it so much more easier for the doctors. You've got conversational AI now where the doctor sits in front of the patient, they're talking to each other. And all the private conversation is also left out by the AI, and it just picks up exactly what is required. And it does a fantastic job. It's actually reduced a huge load for people. I think I've been a little bit more tech savvy, so I might be a bit more biased, but I think it's made a huge difference for us. You've got chatbots on your website. You can automate so much because it can improve your communication, as real time. And that's perfect for people.
Yeah, absolutely. And then there are, I think, AI bots coming, which can also call the patients, take,
Yeah, you've got voice modulated, voice automation. So
Yes.
you've got something like an Alexa in your room, and you can order your orange juice by just asking for it. You don't call it Alexa. You can say whatever you want. So you can say, "Hey, Team Rella, can I have an orange juice?" And it'll order you an orange juice. And you can ask for your bill, and it'll tell you what your bill is. So it just cuts the middleman there. But of course, I think that you always will need some people for that a little bit of human touch that is really, really required.
Now, Farooq, the next question is around operational efficiency. Since you have invested a lot of time in hospitals, you have seen the operations very closely. Where do you think hospitals lose most efficiency? Is it the clinical workflows, administration, or patient services, or something else?
That's a fascinating question because we've had a few meetings where this comes up, and then every department will try to point a finger at the other department. But I personally believe that the inefficiencies in hospitals rarely comes from one area. No, it's generally the gaps between the areas. And think of a clinical workforce. Any workflow that's clinical. Now, if there are issues with documentation, handing over, technology not well integrated, if you try and ask a doctor to go to the EMR and type it, spend more time in front of a screen than in front of patients, that will create some kind of inefficiencies. On the administrative part, I would say, what do you say? Process duplication, paper approvals that are there, heavy systems, paper heavy systems that we create, and multiple silo departments that work in silos, really. And in terms of patient services. Patient services is what you said, right?
Yes.
Patient services, I think it breaks down when they have to fragment between departments, really. So I think it's more of the gaps between the three main workforces there.
Farooq, I've also seen that it's, also in like kind of big hospitals, the follow-up mechanism is not good. So let's suppose I booked an appointment with a doctor today.
Mhm.
And I was not able to connect with the doctor, on that day. I've seen very few hospitals, say one or two, kind of calling me back and asking that what happened. And, you know, do you think, the CRM, especially in the hospitals, needs to be better designed, or your suggestions on that?
No, I think so. I think so too. I think there are a few new CRMs that are coming up which automate it. The message automation has been there for a while, but now they're bringing in automatic voice calls also to find out and to remind them to come in for their appointments. You've also got a few companies who come and try and outsource that. I think in terms of that particular callback, I think it's very important that is done. It is important because the patient has to be part of their own care. So one is you have to try and include them in their own treatment. Number two is you need to ensure that they become compliant. So a bit out of topic here, but I'll tell you one of the things that we do through another company. What we've tried to do is, when you use a credit card, you swipe a card, you get some points, and you can use those points to get whatever you want. And if you notice it, if you've got a credit card, you'd prefer one card, some points, and that, if I use it a little more, I can go out and get something nice or, get an upgrade for my flight. We want to bring in a system which is very similar to this. Of course, hear me out. We don't want them to use the hospital more. Yes. But this is to try and make them more compliant. So we give them points, but the points are not for using the hospital. The points are to be compliant. For example, you've come back for your appointment, or the doctor says, do 3,000 steps or 10,000 steps a day. and
Yes.
they come back after 2 weeks, they show a phone and they've got 10,000 steps a day. We give them back 500 rupees. We say, you know what? You've done something for yourself. Here's 500 rupees. And you don't need to use them in the hospital. You can use them wherever you get an Amazon voucher or something. You lose weight when the doctor asks you to lose weight. We give you money. You take your medicines on time. We give you back some money that we've made out of you.
Yes.
I think it's a good thing to do. I think everybody should try and get into this particular concept. This is very close to my heart. We very recently started it. So how good and great it becomes, maybe I'll be able to tell you the next time.
This is very nice that a hospital leader in India is talking of this. I'm superbly happy when I kind of hear it, because this is really beneficial, because people will take care of their health, and preventive healthcare is so very important that
No, I
hospitals.
think so. Very true.
And Farooq, a lot has been talked on. If you go on a lot of review sites like Quora, LinkedIn, people are not happy with insurance. A lot of the times you will see people posting about insurance claims not being processed by the insurance companies. Things didn't work out and all that. How do hospitals can work closely with the insurance companies, or the other way around, in order to make sure that that experience also becomes very streamlined?
I think when you compare to where we are now to about 15 years ago, I think we've shown a good improvement, in terms of a lot of care being covered by insurance rather than out of pocket pay. But as a country, that's still way lesser than it should be. So most of the pay that happens still is out of pockets. Patients have to come, they have to pay for their healthcare, and the government doesn't look after it. I mean, the government does a good job, maybe in primary and secondary care, but in terms of tertiary and quaternary care, there's a big gap. And this is where you've rightly said the insurance companies have to step in. I think our regulations have to be a bit more stringent in terms of clarity and understanding.
Yes.
In most of the countries in the West, it's very clear as to what's going to be covered, what's not going to be covered. If it's going to be covered, it's going to be covered. There's no small fonted lines
Yes.
that you have to go through. Really.
Yes.
But you can't blame them, because even they have to cover people. So I think it's a hand-in-hand approach. What we also try and do is see where we can have insurances used. If we can bring in other modules that help at least bridge some kind of a gap for patients, in terms of affordability. But they're not as bad. I think the follow-up, yes, in terms of, if you ask me, can there be better follow-up between the insurance companies and the insurance companies, hospitals? Absolutely. Absolutely. A huge way to go.
Now, the next topic is related to healthcare marketing. And we all know that it's a highly regulated and sensitive thing. So what are the key challenges? And since you have been a part of the hospital, you have seen that, marketing happen. What are the key challenges that you think that, is there while you are positioning a hospital brand globally, and with, making sure that the credibility is not at stake?
I think that's a very good point. I mean, there are some regulations in place, and that is good. And I think it's good to be stringent there. I want to break that question down into 2 points. Okay. One is what I generally also say. So when we say marketing in healthcare, a lot of people think it's a bit of a taboo. Oh, how can a hospital market? But marketing it's not just sales. Marketing is also letting people know that you've got a solution for a problem that they have. Technically speaking, that's what marketing is, nothing else. So in terms of marketing, it's not a bad thing. But yes, like you've rightly mentioned, I mean, healthcare, it's not like manufacturing industry or any other service industry, because you're not selling a product per se. I mean, you're dealing with people's lives. Yes. So in terms of marketing for hospitals, I think the word that you maintained, that you mentioned, credibility, it means everything. Yes. That helps you position where you are and who you are. And of course, there are regulatory variations between one country and another. What might be extremely sensitive to one part of the world might not be even published in another part, really. Yes. I think 2 or 3 points are very important. Is you cannot overpromise anything. I mean, you need to be absolutely certain about what you're saying. Yes. You need to stand there. Sometimes in our country, we are known to flaunt numbers, yes, which I think is reducing over time. But I think we've still got a long way to go. At least if you go to the West, people can't just come out and say, oh, you know what, we've got about 90% success rate. So I had a meeting once with the government. Went there, I said, oh, you know what, we've got we've got one of the best success rates for transplants. And we have a 1 year survival of 99.2%. And you go, oh, India, everybody's got that. And I was shocked because nobody else had that. But people just say stuff like that, but I think that can be regulated a bit. See, people look at it. This age, most of the marketing that happens is digital. More than a billboard, I think you're in everybody's palm on their phone, really, and everybody's looking at what you're saying. So you can lie about what you're saying, but when people find out that it doesn't match with who you are, people understand that. Sometimes it can take some time, but people understand that. So if you're being honest, if you publish your results in India, that's something again that we are actually pushing the government to have. We don't want them to make it compulsory. We understand it's a big process, but we publish our results. So, I mean, if you want something done, I think you should first come out and say that I'm going to do it. And, it's a good idea if everybody does it. Because on the Western side, they should look at India as to where we are, because we're actually doing a fantastic job. At this cost, giving these results is fantastic. And I think that needs to be promoted. So yes, a lot of publications and in good journals, making sure that you talk about your results, not lying and not over promising are things that have to be, that's like the basic thumb rule for everybody.
Farooq, the system is very disintegrated in the sense that, let's suppose today I went to a doctor and I got some reports, and then after 6 months I'm going to another doctor. The information exchange is missing, right? And that kind of it hampers my overall treatment as such as well. In US, if you see,
Yeah.
they will give you an appointment and you have to go to the same same
Well,
doctor.
at least in London, yeah, and at least for the NHS, yes.
Yes. So how do we make sure that the entire life cycle of a person, let's suppose, right from, childhood to he becoming an adult to an old person, the entire repository is being shared across hospitals without compromising on the privacy of data?
So I think the government's already working on that. That's a good initiative as well. They're trying to bring up a medical ID that can be shared across to any hospitals. Of course, either the hospital will have to approve it based on patient consent, and that can be shared as to whichever hospital. And all that data is going to lie there. And it's a good thing for the government to oversee that data, because we can use a lot of analytical tools to actually understand what is required in which part of city, how people are doing, a lot to do in healthcare there. But within hospitals also, I think that is a bit of an issue, I'd say, because sometimes there might be, when you look at technology, people invest so much in technology and there are still gaps there. The smaller hospitals will have a file. So they'll just go take the file, look at it. Other people will have it. But because the way technology has come into healthcare, it's evolved over time. So people have got multiple different products that have to speak to each other.
Right.
That can be a bit of a lag. And I think the gap that's there is, it's never in technology. It's generally two questions: why and how. So when leadership or any management is trying to bring in some technology, they are thinking about either efficiency in terms of financial gains or patient or results, or return on investment.
Yes.
So the same feel has to be translated down to the doctor, to the nurse, to the administrative staff.
Right.
And you have to ensure. So there are 3-4 things that you have to ensure that has to be done. You have to make sure that the right people are involved in making the decision while you're selecting those tools. Then change management, which is a tough task wherever you are. But there are ways to do it. And I think people eventually might resist to change, but then they slowly, once they understand that it's easy for them, they're happy to change as well. And finally, there's no training. So everybody, after a particular point of time, doesn't want to say, I don't know how to use it. We've been working it for the last 6 months, so I won't use it. So that's another thing that can come in. So training is also very important.
And Farooq, if you see the hospitals, like, everybody's damn busy. Like, everybody's busy in their tasks. They have their roles and responsibilities defined, and it's a very critical work that they're doing. So have you seen hospitals coming out with kind of a department which is like innovation department, or, the team which actually keeps on seeing how to improve the process, process improvement, maybe a separate team, 1 or 2 guys who are working on that?
Yeah, absolutely. It's always that. I think it's recommended as well. It's recommended to have a technology team, or even some hospitals have actually gone to the point that they've registered a different company that looks after that for the same hospital. Was initially a part of the hospital, and then it's a separate company that oversees it. But I think that is very important for you to try and see how you can always improve, and they will catch up all these tweaks. Because if it's the same people, if you're in the system, it's very difficult for you to come out and look at it from a different angle. So I think that is something that every hospital should invest in.
And I had this question around, hospitals have started investing in digital health tools, but adoption often lacks. But I think you have already answered it, those 3-4 pointers.
Yeah.
If you want to add anything, like, why do digital adoption lacks, especially in case of hospitals?
No, I think the same thing. I think it is going to be when people don't feel that they're involved, or if they don't think this is the right product, So involvement becomes very important, and I think training is a must. But I think when you're trying to bring something in, everybody needs to understand this is the vision of the hospital. This is what we want to do, and this is how we want it. So these are things that's very important to make sure that you work as a team rather than just working in silos, because that's very true for hospitals. One huge lag point.
And Farooq, also tell us, a bit about how are you using, AI and analytics, especially in the day-to-day, solve the operational challenges.
I think AI is fantastic. I think AI is, when you look at the engagement, I mean, it's already reshaping, the way we deliver care. I mean, it's not just theory. I mean, right now we're using it. I actually tell people, when I give a talk, most of them are like, do you think AI is going to replace people? And I tell them that, look, I'm not sure if AI is going to replace people, but a guy who knows AI is surely going to replace the guy who doesn't know it.
Yes.
So it's very important that you go with the flow. You need to know how to use it, make your life easy. It makes you more efficient. That said, I think some interesting things. One is we actually can use AI as a predictive analysis. So we do two or three things. Okay. So we can use AI to understand and predict the length of stay for patients. And that helps us in our admission process at a later point of time. We've also got some AI tools which we use from outside, which help identify sepsis even before it's detected on tests.
Yes.
We use AI in radiology. It helps. I mean, the radiologist will still have to go through all the X-rays, but it can red flag a few that they have to go through first, as these do have an issue. We use it. We do a lot of research also. We've got a fantastic pathology department, so we're trying to make a generative predictive AI to actually find out cancer, diagnose cancer before it can actually be seen.
That's nice. And the next one, I think, is usually a big headache for all, CEOs inside the hospitals, especially is to manage this large healthcare workforce, managing the expectations of doctors, nurses, and all the administrative staff. So what are the biggest people related challenges that you encounter on your day-to-day, level, and how are you, trying to solve them?
I think it boils down to two things here. One is it's the culture. But I think if you look at a challenge per se, if you look at how people have to be staffed or trained, and how do you retain these things? So when you look at it, I think burnout and retention of people, that becomes two main challenges that, for example, you can staff people, you can build a fantastic ICU, you can train them. But if you can't retain these guys, then you're just on a hamster on a wheel. You're just running around the same circle, actually, So I think culture is important. It has to be top down. People should understand that it's safe. People should understand that this is the thing that I'm working towards rather than just coming to work and doing something that they're supposed to do. Recognition is important. Growth is important. Upskilling is absolutely important. So I think trying to take care of the team that is in house as part of a large family is key. And that is a major issue. And then if you look at it now, my attrition for nurses is all-time high because now NHS has opened up. Initially, they used to go to the Middle East.
Yeah.
But now London wants them, and most of them go. You don't want to block it because, they are actually making a life for themselves.
Yes.
And it's a good thing, you only feel happy for them. So at any point of time, at least in my ICU, if you notice, there'll always be nurses who are getting trained. And managing that manpower also is very important.
So do you guys also tie up with these,
We do have, at least with the NHS and the Royal College, because we do a lot of training courses for the Royal College here. We do a certification program for them. When they come here for interviews, they come here. We are one of the main centers that they come to. They also select a few people. We encourage a few people to join. We also try and train a few people so that they can go. So people understand that, look, there is some growth for me. If I'm here for about 2 years, I do a good job. And if they're making a life for themselves, it's still a good thing. I mean, they're anyway going to go from somewhere. You might as well make a ladder for them so they understand that, that they get that closeness. They always have that feel for the hospital. And I think we should do that.
Farooq, I've got one thing in my mind is that there's a concept called, remote ICU concept also, kind of coming up. It was already there in the US and Europe, but now in India also. Yep. Your viewpoints on that, if you could explain our audience, what is remote ICU, how that works?
See, technically speaking, an actual remote ICU would be some place where, let's say there's an ICU elsewhere.
Yeah.
All right. And they do not have the right staffing. They do not have the senior doctors there, but they've got some doctors who can manage it. What we do is we manage it from a different center. So it's like a call center managing an ICU. But of course, that center's got the adequate senior doctors who are looking at it. All the tests are tagged, the video cameras are there, they look at it. During COVID time, we did it for a couple of hospitals in Australia, because they were outstaffed. I mean, generally, if you look at staffing also, what happens is the manpower is generally seen as an average for whatever it is, unless you're a high volume center. Because we are a high volume center, we need to plan for the peaks that you can get. So we've got some people. So we used to do that then. Now they don't have the need, so we don't do it for them. So the patients are there, the machines are connected, machines are seen here on the computer. There's a video that is shot continuously, and there's somebody here looking after a patient in a different region. So it was somebody sitting in Chennai looking after a patient in Australia. And if something comes up, any medicine has to be given, something has to be done, they will tell them what to do from here. Of course, when you go to a country like Australia, they've got some regulations as to who can be a doctor that can prescribe, and they need to have the right qualifications. So it happens here. We did this. What we also did is we put our own ICU beds also on a camera. So we've got a backup on the same center. So whenever they do it for some region, either Maldives or Malaysia, other than that, what we do is whenever our patients are there, they have a look at them also. So we've got a dual check for our ICUs, which is a good system.
And it can be a game changer for tier 2, tier 3 cities also, Farouk. Like,
absolutely. I think so.
Like the bigger hospitals can establish their own.
Yeah. I mean, if you look at it, so you've got teleradiology where you take scans and then these scans over the internet come down, somebody sees it and sends you a report. Radiology. Telepathology is the same thing for slides, and then you've got tele-ICUs. So, and of course, video consultation, telemedicine, all of that is there. So, and post-COVID, I think it's been a bit more nicer. Even though if you notice, the video consultation, other than abroad ones, have actually come down. I think people, at least here in India, want to sit in front of a doctor, get that feel of, "Pata sir, kya hoga?" But I think that's good. I'd prefer that.
Yes. That human touch is always important.
No, absolutely. I think so too.
Now, one question, since you actually touched upon international markets, is that, where do you see India being placed in terms of attracting international patients?
I think India has been a hub. Tamil Nadu has been a fantastic place. People, I mean, if you just look at how Tamil Nadu alone has done, they've done a fantastic job. Now, when patients are coming to you, they are most vulnerable, because they're coming to a different country. They don't know the people there. They don't know the language there. They don't understand the food there. It's the most important thing for them is to build trust. And I think it's very important how you do it. So even before a patient actually arrives here, there's a team that's spoken to them, that they've seen on video, now in video. Initially used to be WhatsApp calls sometimes, but or at least on the phone. Now they've seen the person who's speaking to them. They've spoken to the doctor who's going to treat them. The consult has been done. They help them with the visa. They help them with the transport. They help them with the pickups. They help them with the local stay, the food. Two things is clarity and being very, very open. For example, sometimes patients come to us for transplants. Now, for transplants, it's very important to tell them that, look, Indians get priority, foreign nationals don't. And it's important to let them know that before they come here. Because if you don't say that, technically you've not lied to them, but you've withheld information that would have made them choose maybe not to travel. So when you explain everything to them in detail, then that trust is there. People understand that they can come to you with a problem. They can tell you what they want. And I think that's very important. The second most important thing is sensitivity to their culture. I mean, languages, you need to have translators, food habits, the type of food that you get there. We've got halal, our hospital is halal certified, and how the care is supposed to be done. So I think the cultural training, your support systems here locally, the dietary preference for people, when they travel, all of that has to be taken into consideration. And finally, of course, they want to compare you to somewhere where their people have been. So some people travel to the West and they want to compare it to the West. They understand that because everybody's got a very different perspective on India, but I think based on how we have been, I mean, when people come here, they enjoy Indian food also after a point. Biryani becomes one of the meals that they have. And I think as Indians, I mean, maybe you'll see that a little bit in Maldives and Sri Lanka, even though they are not countries that people want to go to. India, we believe in Atitha Devu Bhava. God is guest. At least down south, I mean, people come here, they're treated in such a nice way.
Yes.
And people like them. I think that is what is very important. Because see, when they go back and if they've not been dealt properly, they're not going to say, you know what, I went to Rail Hospital, that was bad. Say, I went to India and it was terrible.
Yes.
So I think that's a collective responsibility that we need to try and make sure that is kept at a very high standard, or at least a very high pedestal.
And do you also keep in touch with them, Farooq, like once
Oh,
they go back?
absolutely. Absolutely. Oh, so Dr. Ella is known. So
Yeah.
the hospital that I work with is named after my chairman managing director, Professor Mohammed Farouk. So he got a Guinness Book World Record because he operated on a 5-day-old girl. She's 27 years now, 28 years now. So we're
Mm.
still in touch.
Yes.
So the idea is like, just because you've gone back doesn't mean, and
Yes.
we encourage them to get local treatment whenever it's
Yes,
possible,
yes.
because we can't expect people to travel all the way here. That is okay. But we want to be in touch to ensure that they're doing well. And we've got a huge team just to take care of that.
Yes. To
So not
advise them
only
on.
international patients, even patients within India.
Yeah. Now, my last question, Farooq, is that this was very insightful, actually. My last question is that what would be your advice to the leaders, to the hospital leaders who are exploring innovation, wants to implement digital tools in their hospitals? Your advice to them in order to make sure that they do it correctly.
Okay, that's good. Because you said this is for the people who want to start doing things. I'd say, okay, I think that people, when they're taking decisions, they should actually start with what the problem is and not the product. Generally, people cannot differentiate between them. People see a product, I like this product, why don't we have this product? It should be the other way around. They should say, I've got a problem, and how do I solve this problem?
Yes.
For example, I have a long ICU admission rate. Then I need something that can help me reduce the ICU admissions. So if somebody can predict it, if somebody will tell me that this patient is likely to be shifted into ICU, extra care can be given and that can be avoided completely, or readmissions can be avoided completely, then I need to go in for that particular solution rather than somebody coming and saying that this is also an addition to something. The second point would be you pilot something that you want to bring in, and then you don't immediately plunge into something. So if you need to pilot something, you run it on a very small scale, put it as a time bound project, see what it looks like, define your success, define the metrics that you want to call it successful. Then you go ahead, because it de-risks the investment that you're going to do. And finally, very importantly, at least that I've learned out of experiences, choose partners, not vendors. People should choose people who are willing to understand you, understand your workflow, and help you adapt and co-create what you want, rather than just being a vendor who gives you a product. So at least to bring in innovation, I think these are the 3 key points that I'm practicing.
Absolutely insightful, Farooq. I think this is one of the best podcasts that we have done, especially with the
You're
healthcare.
being very kind. You're being very kind. Perfect.
Thank you so much, Farooq, for joining us, and thank you
Thank
so
you.
much for this insightful
Thank you,
discussion.
Rishikesh. Thank you so much for the opportunity. Thank you. See you.